Hello everyone, welcome to Physiotherapy in Lesotho, www.physioinlesotho.ch. You are listening to a podcast from one of our physio workshop in Lesotho. Your speaker is Thuso, W. Fasser, a qualified physiotherapist.
Physiotherapy in age-related condition. Why do we highlight this topic this year? We do highlight it because so many of our patients in the hospital, they have somehow an age-related problem. And as now the drugs are here, as the situation starts to improve, we can see even more the necessity of rehabilitation, not only the physiotherapy treatment when patients are in the hospital. We can see the need of rehabilitation in home-based care and when people come to the health center to help them to get along with their life which they now receive due to these drugs. So the big AIDS crisis, we could say, is over. We are no longer as hopeless as 10 or 15 years ago towards that problem. So there are new necessities and we can identify much better what are the areas in age-related problems where physiotherapy can be from help to improve life quality of people who are infected by HIV. So if we think about what are AIDS-related problems where physiotherapy can be from help? If we look at the hospital when people are very sick, maybe in advanced stages, or when they just have these super infections, when they are very sick and come to the hospital. In hospitalized patient, we can see the patient who have infections on respiratory tract, these pneumonias, very strong bronchitis, these infections on the respiratory tract. Or when they have TB, AIDS and TB. So strong affections on the respiratory tract. If we have cases like this, we help them with just the ordinary respiratory physiotherapy. We help them with positioning, with drainage, postural drainage, with percussion, vibration, the proper cuffing techniques to be able to cuff productively, to clean the lungs. We help them with ventilation exercise, deep breathing exercise, and as soon they are a little bit stronger, not as weak anymore, we can start with gentle exercise to mobilize the chest, to activate the respiration and to activate the flow of the sputum in the airways. The therapy is very similar as to TB patient. Last year we were talking about the new and fresh concept for TB physiotherapy, and we were saying we have three groups of patients: the very weak ones, then the moderate ones, and then the already quite advanced cured ones. So we could say the weak one, the less weak one, and the strong ones. So it's very similar with AIDS patients. We just judge them. Is that patient very weak, very sick? So we do individual treatment to them, respiratory care. If the problem is liquid in the lungs, if they really have a lot of sputum, we do a lot of drainage positioning, gentle percussion, vibration, exhale exercises, and gently exhale and cough exercises. If the problem is that the ventilation is so superficial, but it's not really the problem of a lot of sputum, so we do deepening of ventilation by gentle mobilization of the chest, the skin rolling, the pulling on the skin, gentle vibration, and probably with the straw, so that we increase inhale and it becomes to a reactive exhale. We do this type of exercise, maybe passive movements of the arm to increase the flow, the ventilation. And when patient gets stronger, we start to do exercise in sitting. So if we have an AIDS-related problem in the term of respiratory dysfunction, by infection and so on, we do the proper respiratory tract therapy. We will do the practical on that later. So similar treatment as with TB patient. What we really have to observe there, follow the patient's condition. Follow the patient's condition. If they are weak, do a very gentle but regular therapy. Maybe I go twice a day to that patient. I do something very mild, very soft, gentle to them. Don't force them too much. If we force them, they cannot react to that stimuli. So just do very gentle treatment as a very sick person is needed. When they are getting better, start to do a little bit more. The treatment can become longer. Maybe from 10 minutes it can become 20 minutes. If they get better, if they start to get mobile, you can start with exercise in sitting, and the percussion can become a little bit stronger to them. A rule is when the person is very sick and has a huge infection on the lung, don't force them. Do therapy with them, but don't force them, because if we force them too much, they get too tired, and then the already weak immune response cannot come. We overforce the patient and we are weakening the immune response. So just do it very gentle if the person is very sick, and then by time gradually you can come up. For this patient, the priority is that they have the drugs which the doctor is prescribing them. And the doctor will look at them, how the drugs are reacting, if things are going on. In that very weak stage, in the hospital, we are not working with Artemisia T. If you have a good relationship with the doctor, if the doctor is informed what is Artemisia, I know clinics in Tanzania and in Zimbabwe, they are using Artemisia with a very good success. But if you are not in a hospital where it is introduced, let's do the doctor what they are doing with the drugs. That's fine like this. Don't interfere. But when they start to become stronger, Artemisia T can be very helpful. Even the onion water or some garlic water can be very helpful. If they have difficulty to breathe or even to cough because they have the sore inside of the mouth, onion water and doing gargarism with onion water, not drinking it, rinsing the mouth with onion water helps to that wound in the mouth. The sore spots in the mouth can be really helped by onion water, gargarism of onion water. It's not something very pleasant, but it's very helpful. The onion water, no, sorry, I made a mistake. The garlic water you have to rinse. The garlic water. The onion water you still can rinse, you can drink, but the garlic water you are not drinking. You're just doing like this. So if you have sore spots in the mouth, the garlic water for rinsing and onion water for rinsing and even drinking, it helps to boost up the reaction. If this is a problem that patient cannot cough. So these are the respiratory problems in an AIDS patient. I would say these are the most frequent problems you see in AIDS patients who are in the hospital. Which physiotherapy can help is the respiratory tract problem. Another group of AIDS-related problem are the neurological problems. AIDS patient can have, as we know, the very simple peripheral neuropathies. That means somehow the peripheral nerves are the source of pain. Sometimes pins and needle or numbness. The pain somehow is inflamed. So the nerve is inflamed, gives pain. This can come due to the infection or due to the treatment, the medicine. So the medicine can make this lateral effect. So pain in the leg, pain in the shoulder, arm region mainly. It's not really on the chest, sometimes here on the shoulder, but it's more the arm and the leg. And these pins and needles numbness or mainly pain due to the drugs not in all cases, but in quite a few cases, can be helped by moving that extremity, massaging gently that extremity, and stimulating with a brush or something, just stimulating the skin sensation. We do this very same treatment, movement, massaging, just touching, moving it, and stimulating with a brush. We do the same treatment in polyneuropathy. When the nerves somehow are degenerated, we do the same. In the feet, maybe old people who cannot feel any more the feet properly, we do that same treatment. It doesn't help all the time, but sometimes it really helps. So we do that type of stimulation, not too strong, not too long, but regularly. And look as the patient is reacting. Sometimes it helps them together with the vitamin which they get from the doctor. So it's not hopeless if somebody by the medicine has these neuropathies. It's worthwhile to try to this stimulation with physiotherapy. Gentle massage, gentle stimulation with a brush, and moving. If it is on the foot, you can do that foot bath. It's a nicely warm foot bath, not too hot. And we wash the feet with soap, so you have that feeling of soap. Then we wash it with salt. You have that slightly rough stimulation of salt. And then you massage it with oil. So you have 3 types of quality of sensation. This is a very good stimulation. We use that treatment for polyneuropathy, when we use it as well for paralyzed people who don't feel the foot good. And you can use it for this neuropathy patient, AIDS-related neuropathy. You can use it and try it. Do it for 2 weeks. Look, if you can teach a family member, if it helps to them. If it helps, go on. But you have to do it at least for 2 weeks. If you do it once or twice, you cannot expect a result. Have you seen patients like this with this pain in the arm and in the leg, these neuropathies? Yes. Sometimes here in the face too, huh? Yes. Okay. Now, neurological condition, what we see sometimes is the facial paresis, the paralysis on one side on the face, so the mouth is hanging down. Normally, it's a peripheral paresis, so that nerve coming out from the brain is paralyzing, so they cannot close the eye properly, and the mouth is hanging a little bit down. There, you do the ordinary facial expression exercise therapy. As we have sometimes, somebody has a cold and then he gets that paralyzed, or he has a bang somewhere on the face and he gets it. If it is a peripheral facial paralysis, you do the same training as we do in all these type of paralysis. So we are stimulating, we are massaging the cheek, and then we're doing facial expression exercises with the mirror. Slowly but surely, you can try to do that. Sometimes it's due to an infection in the brain. There is some abscess in the brain, and resulting in that. So doctor will give the medicine, and you start to do the same treatment. You just try to treat the symptom, that facial paresis. You do that. If the patient has a hemiplegia, hemiparesis, due to that infection in the brain, of course he needs to be treated by the antibiotics, but as soon he gets a little bit better and he's stable in his medical condition, start to do hemiparesis treatment as you do it with a patient who has a stroke. It's the same treatment. We do early neurorehabilitation with them. You just go on doing. The chance of recovery is even better as in a hemorrhage patient. Because it's an infection, if that infection is finally cured, the nerve, they can somehow recover. If they are damaged by a big insult, if there is hemorrhage, the prognosis is not as good as in these infection cases. So we saw sometimes infection, as soon they got the antibiotics, started to respond, things became more easier, and physiotherapy was responding to it. So if they have a facial paresis, you do the same treatment as we do with the ordinary facial paresis. If they have a hemiparesis, you start to do early neurorehabilitation. That means you do the positioning in the bed, you change position, you do the transfer to sitting, you let them sit in a chair, you start to stimulate if it is floppy, you start to relax, to do spasm reducing movement and position if they are spastic, and then you concentrate on primary function. Turning in the bed, sitting up, sitting safely on a chair, standing up, standing safely, starting to walk with help of somebody, and starting to learn to dress yourself and undress yourself, washing themselves. These are primary functions, and we are concentrating on this primary function. So you treat them as a stroke patient in the early phase, early neurological rehabilitation. You can do that. So what we see sometimes as well, that the AIDS infection has somehow infected the spinal cord, and the person has a paraplegia. Somehow strange paraplegia. It's not the typical one. It's strange. Some movements are there, some are not there. Or there is no sensation. You can have everything in these paraplegias. It can be very high up, and then you have tetraplegia, both arms and the legs are paralyzed. These are the more severe cases. But if it is paraplegia and you have some function, you start to do rehabilitation. And you just have to look, how is the disability? What can the patient do? What can he not do? And you start to exercise what is possible and to help to recover in primary function. If it is necessary, they need to have a wheelchair that they can be a little bit autonomous. But the rule of the thumb, as we call it, is you check in how is the disability, what he can do, what he cannot do. You check in the medical status, and you check what is the topic of the treatment now. So if it is autonomy, so you work on autonomy. If it is of basic function, turning in the bed, sitting up, you work on basic functions. If it is strengthening muscle strength, maybe on the hip or so, you work on that. Just have a good look as it is, because every of these paraplegic is a little bit different. And if the paralysis is just from little age, maybe a month or two, the prognosis is much better. If it is already there for a year or two and then they start with treatment, the prognosis is not good anymore. We always have to consider the medical status. If the person is very sick, has other infections too, so there is not enough power for a good rehabilitation. So if the person is quite fine, is stable, the CD starts getting better, there are no other super infections, so the patient is fit to do a good rehabilitation. We have to consider case to case. Nobody is the same as the other. So these are the neurological conditions where we can see. Now, another thing which we can see, apart of the respiratory problems, the neurological problems, it's a more minor problem, is that people are generally weak. They maybe were lying around, they were maybe not nourishing themselves properly because they are so sick. Maybe but they were lacking resources. Maybe they were continuously sick and they couldn't really cope, they couldn't go out. So they were too weak, they were not exercising themselves, and they have a loss of fitness, a loss of body training. You were jumping around this morning, you were running, you were talking, you were singing. So you were training your fitness. You are fit. But somebody who was maybe 6 months weak, he was coughing, he was feverish, he couldn't sleep well, he couldn't eat properly. So he's generally weak, not primarily due to the disease, but the consequence of the disease, secondary. So that person will build up power by regular eating, by having the drugs, and then we can start with a very gentle but constant building up training for general fitness. So general fitness means just exercising every part of the body, for walking, for sitting, for the arms, for breathing, general strength. So we have to build up progressively, step by step, physical fitness. And we have to do it very gently. We have the same experience with the TB patient. You remember the very weak one? We treat them in the bed, in lying position. The very weak one, individually. When they are no longer as weak, the moderates, so we start to do exercise sitting on a chair. When they are more advanced, we start to do exercise in standing and in walking. So step by step, the very weak person has to have a step-by-step, a progressive exercise program to build up physical power. And it has to be done very regularly. Don't rush, don't too much, but do it regularly and measure it for that what the patient is able to do. How can I understand I have done enough? I have done enough when the patient could cope to my exercise. Maybe he was breathing, maybe I was saying, oh, I'm getting tired. But if he could cope to the exercise, and when he recovered after just a little time, let's say after half an hour, he said, oh, I was tired, but now I'm okay again. If he says after half an hour, I'm okay again, that means he recovered in a short time, then it's fine. If he said, oh, I could do the exercise, but for the whole day I couldn't do anything because I was so completely tired, then it would mean I had done too much. So when the recovery time is longer as half an hour, that means we have overloaded the patient. If it is within half an hour, that's fine. If he says, yes, I could do the exercise nicely, I'm fine, I could even do some more, I'm not tired at all, that means, yes, you maybe can do a little bit more. How can you do more? You can do more by doing 5 minutes more. You just make longer the duration of the exercises, or you can do it a little bit tougher. So look, can the patient follow? How long is the recovery time? If he has a recovery time longer as half an hour, maybe slow down the exercise a little bit. If he doesn't need a recovery time, you can increase the exercise. This is a very good rule. You just watch it and you ask and look at them. And then you do it regularly. Normally in the first week, if you start to doing such a program to a weak person, you have to do it very gently. Why? The patient shall have an experience of success. If you are successful, you are invited to go on. If you are frustrated because you don't succeed, you don't feel invited to go on, isn't it? If you have an experience of success in this workshop, you will be motivated to do these things at home. But if you would go out here of that workshop being convinced that you understand nothing, you would do nothing at home, isn't it? Yes. So, I know at home we say, if I feel like a donkey, I wouldn't do nothing. So, no, we have to have experience of success. So, allow the patient experience of success. Do something gentle to them that they can succeed. So maybe we underload them. And then gently we do the proper loading. That means exercise which are tough enough that they can do it and that they can recover quickly. And then later we start to give them more. And by week, we can go on. If you're working to an ART center where you have regular patient, you can offer a physical exercise class there. So people who comes and go, who is there, can participate at that class. Maybe they can start to do it at home. If you are in a health center, you can say, 3 times a week, we have the physical exercise class for HIV patients, so they can come and assist. Because doing in a group exercise is easier as doing it by your own. You enjoy the group, you have the power of the group, that's fine. You just offer that program. And if you are in the hospital with the individual patient, we do it individually on the bedside every day. So they can learn it while doing it during the hospital time, and if they are motivated, they go on doing it. A simple way to build up fitness is just walking. If somebody doesn't like to exercise, at least walk. But I tell you, all-day movements, daily movements is not the same as doing exercise. If you move the joints in a way we are not used, you build up fitness. So let's do nice and interesting exercises to the body. It's much more as all-day movements. Can you understand how I mean that? Yeah. So we have 3 areas of AIDS-related problems where physiotherapy really can be from help. If you think on the hospital, it's all the respiratory problems. It's all about neurological problems. And then it's all about general weakness. We can help to build up weakness. And if patient gets stronger physically, they combat the disease better. And becoming stronger goes hand in hand with ART drugs and with a good metabolism and a good social network. So these 5 aspects which I was talking yesterday, 5 aspects of well-being. So we teach them this aspect as well and will help them. That's what I understand by physiotherapy in AIDS-related condition, and we can be from a nice and potent contribution to this patient. Do we have a question to that? No question. Okay, so we can go to tea time now, and from there we go to the practical about respiratory physiotherapy.